morning, everyone. My name is Brittany Green, Communications Director of the KAT6A Foundation. Welcome to our very first KAT6A clinic. We are delighted to have you all here. We know many of you have traveled long distances to be here to support KAT6A, and for that we are very grateful. I wanted to take a moment to thank Dr. Harris for organizing this clinic and making this possible, Dr. Bjorsen for speaking to us about frontiers and therapies for epigenetic disorders, and also Dr. Kelly for traveling from Massachusetts to share the data he has been collecting and analyzing on our children. Also a big thanks to the KAT6A Foundation team for pulling all of this together and putting everything into place. We have today from the Foundation board members and committees, Jordan Muller, Chairman, Emal Najm, President, Amy Redson, Website, Natasha Esper, Scientific and Research, and Miranda Lentine, Social Media. We all know how rare and extraordinary our kids are, and with the help of these amazing doctors, we are hopeful that soon we will have a lot more information about the KAT6A syndrome. We are looking forward to meeting and getting to know all of you. It is truly a dream come true to have so many of our KAT6A family together here today. Yay.
Also, Rick, we have Karen, board member. Karen Ginsburg.
Okay. Oh, I'm sorry.
Hi, everybody. Thank you so much for everybody who came from near and far to do this. We really appreciate everybody being here. We're very excited about this here at Johns Hopkins and Kennedy Krieger. KAT6A, as you all know, is a relatively newly discovered syndrome, and we know that you all have been sort of patients in search of a medical home, and so we are really hoping that this can be the start of you all meeting each other, and you all meeting some of us, and us taking a really good team approach to helping these very special and wonderful children as they are children and as they go on to be adults. I am Dr. Harris. I am a neurologist and neurodevelopmental specialist, and I work here at Kennedy Krieger and also in the epigenetics clinic at Johns Hopkins. So I am very interested in KAT6A. It has a lot of overlap with lots of other things that I have interested in, and am very excited that you all came to this. Here also we have Dr. Bjorsen, who many of you all have talked to before. So he is here in the epigenetics clinic with us at Hopkins. Dr. Bjorsen has dual appointments here in Baltimore and also in Iceland. So he is around and here and a part of our clinic, but not always present physically in Baltimore. And then we also have Dr. Jill Farner. She is also part of our epigenetics clinic. She is here at Hopkins in the clinic, and also has a strong interest in KAT6A and disorders that are related to it, and I was very excited to see you all. And we really appreciate Dr. Kelly coming all the way down. Dr. Kelly used to be around with us here all the time, but has moved north where it's colder. And we are glad he could come back to be with us today and share with us his work and everything that he's doing with you all and for you all also. So a quick word about kind of how the day is going to go. So we have 3 relatively brief talks. I'm going to talk a little bit about just KAT6A, the disorder, what is known about the patients clinically, and what's not known, and what we need to continue to discover. Dr. Kelly is going to talk about his research and data he's collected in a large number of patients he's seen or collected samples from with KAT6A. And Dr. Bjornsson is going to talk about some frontiers in epigenetic therapy, which KAT6A is an epigenetic disorder, and sort of where we think and hope that we are going in the future. And then after that, we're going to have a lunch, and lunch is informal, as is the rest of the afternoon. And what we really want with that time is to make sure that you all get a chance to talk to each other, because that's some of the most important things about gatherings like this, is you all learning from each other and gathering support from each other, and kids of different ages sort of getting to meet each other as well. But also we will be around so that you all have an opportunity to sort of informally talk to us and mingle with us, and we get to meet you. So hopefully that works out, and then yeah, it should be a great day. We'll wrap up around 2:30 because they're kicking us out of here at 3. And you know, hopefully, if this is all successful and you all enjoy it, we can do another one of these in the future. So with that, we'll get started with the talks. So you heard me say, and I'm sure you've heard before, about KAT6A being an epigenetic disorder. So what exactly does that mean? So epigenetics is basically all of the stuff that happens to the DNA after it's already there. So the DNA code is written, it's down, it exists, but then things that happen to it after that enable it to be read or turned into proteins as it needs to be. And that's what epigenetics is. So KAT6A is a special type of epigenetic syndrome, which is a syndrome that creates a modification to histones. Histones are proteins that inside the cell, the DNA gets wrapped around. It gets wrapped around very, very tightly in the nucleus in the center of the cell, because the amount of DNA that we have in every single cell is incredibly, incredibly long. And so these proteins help it to be compact and be able to exist in every single cell. However, they are not just, you know, rocks that these get wrapped around. They are actually active proteins that have a role in opening and closing to provide this DNA the ability to perform the functions that it's there to function. And so the KAT6A protein actually has a role in modifying these histones. So what it does is it places a mark on these histones that allows the DNA to open appropriately to be read and transcribed. So thinking about this a little bit further, we can group these epigenetic modifiers into 3 main categories: writers, erasers, and readers. So writers are things that add marks to these histones, and these marks can say open up, or they can say close down. There are proteins that erase the marks, so take them away. And then there are other proteins that read the mark. So once the mark is put on or taken off, it looks and says, what is this mark telling me to do? So KAT6A is actually a KAT stands for K is a symbol for lysine, which is an amino acid. The AT is for acetyltransferase, and then the 6A just lets us know which one it is. And so what that means is that this protein actually moves an acetyl mark onto these histones and tells the histones what to do, how to be open or closed appropriately. So you can understand why, if something goes wrong with that particular protein, then a lot of things can go wrong later in the body. Because your DNA is present in all of these cells, all of your cells, and if it's not there appropriately to be written or used the way it's supposed to, then you have many different problems in many different parts of the body. We know that this particular protein, KAT6A, is especially prevalent in the brain, and so that is why that is the focus of a lot of the clinical features that we see in this syndrome. So just to give you an example, you can see that KAT6A is there on top, and there are a number of other proteins that work with it on these histones. They work together in complexes. So one of the reasons that we are able to make some predictions about KAT6A, although we need a lot more information from a lot more patients, is that we know about other diseases that work in the same complex and what they look like and what their clinical features are. So you could see right below KAT6A, there are a couple of, there are 3 different proteins actually, and all 3 of those proteins are known to cause these epidemic diseases. That they all cause certain facial features, developmental disabilities, and things that are different and unique, but also similar to KAT6A in many ways. When Dr. Bjornson talks, you'll hear a little bit more about that, but this is some of the reasons why we think that we can possibly at some point use similar therapies to address all of these disorders, is because they work together in complex, and many of the features that we're targeting are not exactly the same, but are certainly similar. So, we've talked about what KAT6A is and what it does in the body, and you all know that the reason that you're here is that somebody has told you that your child has a problem with KAT6A. So how did this problem happen? What does that mean? So KAT6A is a genetic disorder, which means that in the gene that encodes the protein KAT6A, something happened in your child that gene wasn't correct. The code for that gene was changed and not correct. So how does that happen? Well, there are 2 different ways. So in theory, KAT6A problems are what we call autosomal dominant, which means that if one parent has this disease, has KAT6A syndrome, then there's a 50% chance that any child they have will also have this syndrome. However, we do not, at this time, know of any cases where this has been actually how this has been passed down. Most of the time, what happens is inside, when the baby is developing inside mom, something happens inside the baby only that makes a change in this KAT6A, and that's what we call de novo. De novo meaning new. It happens newly in the baby. So all of the children with KAT6A that we know of currently have this possibility to pass it down to their offspring, but as far as we know, it did not come from any parents. Yes, go ahead.
I think we just saw right on the Facebook site that there's a family in Japan with three of the 4 children in the family have this KAT6A mutation apparently. So interesting. Yeah, but that was pretty recent.
So that mom has thought that something happens there, and what has happened there is one of the parents carries that mutation in their germ cells. So either the sperm of the dad or the eggs of the mom. So we always tell families that on average, if had one child with KAT6A, you have about a 1 to 2% risk. And what that means is that 1 to 2% of people have the mutation in their germ cells, but the rest of the people have no chance of having it. So most of everyone, 99%, 98% of people don't have that, but 1 to 2%. And that's, we often see 1 in 1 family.
Oh, no, that's great.
In your germ cells, either sperm or egg.
But not everywhere in that person's body, because otherwise they would have the syndrome. Okay?
The parents have been tested and came back negative, so they're
cannot, so even if the parents are tested, even if the parents are tested, they can still carry a mutation in the cells that they don't have access to. You understand? So basically the risk is always that 1 to 2%, but that means that 90% of parents, if they don't carry it, are not going to have a child with KAT6. So it's a very minuscule problem. But what we see is that there are occasional families that have multiple kids. But it
possible to test all the cells in the body to make sure every cell is free of mutation.
To follow up question on that, so you have one child that has KAT6A and you have another child that is normal. Is there a possibility that the normal child carries?
No.
No.
This is a schematic of the KAT6A gene. So it's located on part of chromosome 8. There have been some cases where there's a part of chromosome 8 that gets deleted. So the whole KAT6A gene is missing. And most of the other cases that we know of occurs because of a change in the code of the actual KAT6A gene. So it can occur if a whole section of this chromosome is deleted, but it more commonly occurs because you just change one letter in the DNA that then causes that protein to be dysfunctional. So, we've talked about what KAT6A does and how a problem in this gene could happen. So, what does it look like? So, as you all know, thus far, there are only a few reported cases, which means cases that get published in the literature. You all are here, and most of you have not been published in the literature, so we know there are many, many more cases than what are published, but the way that the whole community learns about things is cases being published in the literature, and so far, there are only a few. What we do know is that we know both from the cases published in the literature and cases that we have seen in clinic, that there are similarities of KAT6A to other histone modifier epigenetic disorders. So those other disorders from that picture I showed back there, they have similarities to KAT6A. So we think we might be able to make some predictions about KAT6A from those, as well as from the actual KAT6A cases that we see. So this syndrome was first reported in 2015, so that's why I was saying it's really very, very new. Everyone who has been reported thus far are children. It is very possible and likely that there are adults out there with this syndrome, but we just have not diagnosed them. Yes?
On our Facebook group, there are people who are in their 20s and 30s.
Yes. So we are sure that there are adults, probably even older than that too, with this syndrome. But adults don't go and get genetic testing as frequently as children do. So it's very, very often in these genetic disorders that children get reported first, and then adults get found and reported later. And again, just like we said before, obviously there's a family, and that's why these Facebook groups and you guys knowing each other is so great, because that's a way to get more access to more patients. Because again, thus far, everybody reported has been de novo mutations, so new in the child, but clearly there are cases of germ cell mutations and other things being passed down to multiple children in the same family. There are some features of KAT6A that in the patients who have been reported are nearly universal. So we're pretty confident in saying, yes, these are the features, the cardinal core features of this disorder that we know of so far. Then there are some features that seem to be related. So present in only a few of the patients that have been reported with KAT6A, but certainly present more than you would see in all the general population without the KAT6A mutation. And so those we kind of say, we need more information and more patients to say how closely is this related. So talking first about the features that are considered to be more universal or at least very common. So the first one is hypotonia. So hypotonia means low muscle tone. So this is sort of what people are talking about. You think of it as like a floppy baby. This seems to be, in KAT6A, it seems to be most present in infancy. So the low muscle tone is most obvious in these kids when they are newborn babies. Although a lot of times we know that it persists much longer than that. We think that most of the low tone is obvious, what we call axially, which means in the trunk, the neck, the hips, the center of the body, more than in the extremities, the arms and the legs. And in fact, the arms and the legs can at times, in some reports, be very tight as opposed to very loose. But almost universally, that center of the body, that core, is very loose. The next universal feature that we are familiar with is feeding problems. So these feeding problems are probably very related to that hypotonia that we just discussed, okay? Because we know that kids get very poor oral-motor coordination, which means their ability to suck, chew, swallow in a coordinated manner that allows them to eat is very, very poor. Many children, because of this, end up needing tube feedings. Whether that's a permanent tube like a G tube or a temporary tube like an NG tube. Many kids need feeding by tube methods at some point in their lives. And then reflux is very common as well. All of these things can be related to that low muscle tone, but it seems that this is prevalent enough to be an independent issue that is a feature of KAT6A. Congenital heart disease is also something that is seen very commonly, again, nearly universally in this disease. It is not necessarily or even usually some of the more severe congenital heart diseases. Usually it has to do with defects of the septum, which is the wall that separates the chambers of the heart. So you can have an atrial septal defect, a ventricular septal defect. Both of these, and even these two together, have all been reported with KAT6A. Other congenital heart disease is a patent ductus arteriosus, which just means that the blood vessel that's present for babies in utero doesn't close up the way it should in patients with KAT6A, or patent foramen ovale. There have been other congenital heart diseases reported, but not frequently. These are the most common ones that have been reported. Eye problems. So again, a lot of this also gets back to that hypotonia. So, you'll see that these things are very related to just general problems in the brain. So very commonly, these kids have one or both eyes with strabismus, which is otherwise known as a lazy eye. They can have ptosis, which ptosis means their eyelids droop down onto their eye. And then lots of other vision issues, nearsightedness, cortical visual impairment, other sort of vision issues have been reported, but certainly the strabismus and the ptosis are very common. Skull abnormalities is another one. So craniosynostosis means the skull bones in your head fuse too early. So, you know, with all babies, they're supposed to have these soft spots. And a lot of times, our kids with KAT6A, they don't have those soft spots the way they are supposed to be. Their skull bones got completely fused before they were supposed to, which can create abnormal head shape and have to lead to surgery. Microcephaly is also commonly reported, which is a small head. A lot of the reports talk about distinctive facial features in this disorder. So things that have been talked about are what we call bitemporal narrowing, which means that this area here on the sides of your forehead are more narrow in these kids than in other kids. A very wide and bulbous nose. Then several other features have been reported. Another one that's really common is this triangular or tented mouth. And again, this can come with a host of other things, but these are some of the ones that are very, very commonly seen. And as you can see in pictures, and then looking out amongst yourselves and your children too, certainly all of your children look like you in different ways. They look like their mom and dad, but they also have similarities to each other that are very different than the familial look that they inherited. And then probably the most common, most universal, biggest feature that we've seen is this global developmental delay. So when we say global developmental delay, what we mean is developmental delay in most or all areas of development. So gross motor delay is seen very commonly, meaning they're late to sit, crawl, walk, all of those things like that. This is probably twofold. It's probably partially related to brain disease and partially related to the hypotonia or the low muscle tone. Then intellectual disability is reported universally in this disease. So most of the cases that have been reported are moderate to severe intellectual disability, although there have been a few kids who have been on the mild end. And then as part of the intellectual disability is a prominent language and speech impairment. So a large number of KAT6A kids are completely nonverbal, or if they do have words, their words are very often even behind what their intellectual disability would say their capacity is. So their language is their toughest skill, more so than a lot of their other problem-solving skills. So then we get into some of the less common or possibly associated features that are reported. So one is small burst size. So a lot of these kids are reported to be small at birth compared to what their gestational age would predict. So full-term babies being a lot smaller and looking like preemie babies. Again, this is not universal, but it's been reported in more babies than you would expect with KAT6A. Postnatal or after birth slow growth has also been reported, but this is a lot more inconsistent. Perinatal complications around the time of birth are very common. These may also be related to that hypotonia issue. But a lot of kids with KAT6A are reported to have to be born by emergent C-section. A lot of them were in breech positions. Many needed NICU admissions for some help with breathing or feeding or things like that. Again, much more commonly than you'd expect. Seizures. Seizures do not seem to be common in this disorder, but again, more prevalent than you see in the general population. But when we have seen seizures with KAT6A, they've been many, many different types. So anything from infantile spasms, which is a very severe early kind of seizures, to more common types of seizures later on in childhood. So specific behavioral features. So the answer is we have no idea. So there have been a case or two reported with, who are reported to have autism. You know, there may be an anxiety component to this, there may be other specific phenotypes, but the answer is there just hasn't been anything on it, so we don't know. We know that there's going to be the global developmental delay, and we suspect that there's going to be speech and language more so than other streams of development. But as far as behavioral phenotypes or more specific cognitive phenotypes than that, we just don't have the information yet. Sleep disturbances. So there have been a lot of sleep apnea reports. Could this be hypotonia? Yes, absolutely. And then just sleep cycle disturbances. Really, really hard time getting these kids to follow a normal sleeping pattern and sleeping through the night. How common is this going to be in this disorder? We don't know yet, but it has certainly been reported. Immune system irregularities are something we know from other epigenetic conditions that are, theoretically related to KAT6A. Some of the cases have reported frequent ear infections and upper respiratory infections in these kids. One case is reported with frank neutropenia, which is a dangerous kind of immune system irregularity, but the jury is still out on this as well as to how common this is and whether or not it's really a problematic feature of this disease. Dental abnormalities, again, common in other epigenetic conditions, have been reported. A whole host of things needs to be further delineated. Hand abnormalities. These are minor things, but lots of things reported with these kids. Curved fingers, that's what clinodactyly is. Brachydactyly is short fingers. A single palmar crease on the hand. Again, mild things, but things that we're not sure how related and how much we see in KAT6A versus other things. And then brain MRI abnormalities. Many of these kids have had a brain MRI. Many are normal, many are abnormal. All the ones that are abnormal seem to be abnormal in many different ways, and not totally clear how the abnormalities correlate to the disease, especially when we're talking about that difficult birth thing with the emergency C-section and stuff. It's unclear to say how much of these MRI abnormalities have to do with that, with a difficult birth and things that happen related to that versus how much they have to do with the underlying disorder. So more data needs to be collected on that as well. And so the bottom line is we have to learn from you all. So you all are the best sources of information to tell us what is common in KAT6A and what's not, and what's a part of the core disease and what are just other things that may or may not happen. We need to draw, like I said, from other similar epigenetic syndromes and find out how much overlap and how much difference there is between KAT6A and these. We need to look at the patients already published. And again, we learn most from you all. So thank you for your time. And I can take a few questions and then we'll move on, and I can of course take questions later too. Yes?
I think another thing we were curious to find out is if there are issues around blood sugar and sort of need to persistently snack and craving of carbohydrates, because it sounds like there might be something with other families.
So that's a wonderful question. There isn't anything out there currently about that, but certainly that's something that we see again in other these epigenetic conditions that are related to KAT6A, that they can drop their blood sugar more easily. Sometimes that can have to do with the feeding problems. There may be something more intrinsic and metabolic going on, and my guess is that Dr. Kelly is going to probably touch on that a little bit also. Yes?
So
in regards to birth defects,
Okay.
there's been a pretty wide range of birth defects. Some kids have some kids have none, and then there's kids like Savannah who have a lot. How does that happen? What causes differences in birth defects?
Birth defects as far as different organ systems and body parts that are abnormal at birth?
Correct.
So that can be caused by a number of things. So again, there have been a number of those reported with KAT6A, but just like you said, some here, some there, none here, and so it's unclear which parts are going to be a feature of this syndrome. But there are also parts that we know about this syndrome that can be related. So that whole hypotonia, I know I keep coming back to that, but if you're inside in utero, if you're in mama's belly and you are hypotonic, you don't move around as much. And when you don't move around as much in there, it can actually cause some birth defects, okay? Because you're kind of stuck in one position, and that can cause deformities in the extremities and things like that. So the answer is we're really not clear what's what. But certainly, like I said, the congenital heart disease, the skull abnormalities, those kind of things are definitely going to prove to be a cardinal feature of this disorder. And everything else we got to figure out, is it random in this one kid, or is it something that we have to sort of look out for, even though it's not the most common feature of this disorder?
Thank you.
Of course, yes.
So I'm Cora's mom. She's the youngest diagnosed today. She'll be 10 months next week, and I'm interested in the hypotonia, because what I've been told is that she has hypotonia, but I'm not sure how accurate that is, because she has physical therapy and all that stuff. So she has her trunk support. She's always had really tense muscles.
Yes.
So I lay her down, she'll like hold her head up from a really young age. So she can sit up really well. That's the only like motor skills that she has. Like she doesn't roll over, she doesn't crawl or any of that stuff. And her physical therapist says that like she's compensating. Like she says that she's not using the right muscles to sit up. So I didn't know if like I've been given a wrong information in that it's actually hypertonia and she's just compensating. You know what I'm saying?
Yes.
So that's kind of my one question. And then my other thing was I didn't know about like the traumatic birth being like a thing that KAT6A kids had. Because I went into like my water broke naturally with her, but then I had a 20-hour labor and she was stuck under my pelvis, and it was like a traumatic situation eventually. Like I had to be induced eventually, and it took a really long time. So I didn't know if like I thought it was just like, oh, different baby, different things, but it might be related to her disorder.
Yes. So addressing the second question first, yes, it may be related. Okay, and again, not to keep harping on the same things, but that low muscle tone, right? So if you're not very tight, if you have low muscle tone, it makes it a lot harder to get through the birth canal and to do everything that the baby needs to do to get through the birthing process. And so is that the only reason that we're seeing these increase in difficult births? We don't know yet. But that could certainly be related. But either way, it does seem that the KAT6A kids have more of the difficult births than the typically developing population. As far as the hypotonia versus hypertonia, it is very, very common that kids with lots of different brain diseases, and this one as well, can be low muscle tone in their trunk, in their support muscles, but very, very high muscle tone in their extremities. So their arms, their legs, their neck, things like that. And I haven't examined your daughter, but that is very, very possible. So my guess is you were not given a wrong diagnosis, that in fact there are a mix of things going on, which is very, very common, not an unusual situation. Yes.
Are you aware of any upcoming or ongoing research studies on KAT6A other than the ones that were published?
not currently, but we're gonna talk a little bit more about possibilities for that shortly.
Okay. I'll have one update on that. So I think many of you completed the survey that Dr. Arbolita made available to the community. So she just updated that she'll submit, I think, next week for publication.
Okay.
The results of that. So that'll be a new clinical paper, right? It'll be 76 total patients,
Great.
52 of which will be new to literature. So hopefully that gets reviewed, approved, published within a month, 2 months, whatever the normal timeline is.
6 months.
6 months, yeah.
Yeah, so soon that'll come out. Again, that's not, I don't think that'll be so much research focused as just adding patients to literature, better characterize the disorder.
Which is very important at this stage of the new disease, so that'll be great, yeah.
Jordan, is she living in it?
No.
How do we know? I started that survey, but I don't think I finished it, and I'm curious if I got kicked back out.
Yeah, I would agree, because I did it, but I don't actually know if they made it, if there was no confirmation that I finished it in the right way. So that's why I hope.
Yeah.
Could she give us a list of who's completed it? Do we have access to that?
I don't know. We can certainly ask her for it if she can. We can be provided that in advance. I mean, she did indicate that, you know, at some point she had to go and publish, right? She had to draw the line somewhere for those that had completed it at that point. So I think partially completed ones are probably not included, would be my assumption. But if you felt you completed it and submitted it, I would assume you're good and you're in there. But yeah, we can try to get a list in advance, maybe of all the included patients.
Okay, I'm sorry if you discussed this, I had to step out, but Hudson's primary diagnosis for a very long time was mitochondrial disease. He has a mito doctor down in Houston, and we did a muscle biopsy. And then, you know, we reran some blood samples and did exome sequencing, and that's when the KAT6 popped up about a year ago. So he's actually on a clinical trial drug for mito. It's EPI-743. What are the benefits that you see to treating mito in these patients?
I'm going to defer that to Dr. Kelly, actually, because that's probably what he's going to talk about.
Okay.
Yes.
Is there any information on how well these kids do who have had some of the cardiac surgeries? Do they react different to anesthesia? Are there any red flags?
That's a good question. We don't know about the anesthesia. Certainly that's something that we're concerned about in any kids with low muscle tone and brain disease. So we don't know yet. Luckily, a lot of the KAT6A reported congenital heart disease are mild and sometimes close on their own without requiring surgery. But I think we do need to collect data on that because the anesthesia concerns are a real risk. Yeah.
I have a detailed anesthesia protocol for mitochondrial disease, but it applies really to any trial, and I can make that available to anyone. It's good to give that to the anesthesiologist and the surgeon.
When Hudson had open heart surgery down at Memorial Hermann in Houston, they developed a protocol just for him. They did something very different.
This actually is a standard protocol used here at Johns Hopkins.
Okay.
So it's somewhere in the process of being published by the anesthesia group, but I can make it available to anyone. Just email me.
Yes.
I don't want to monopolize. So Cora has a PDA that they found, early on. And they're like, oh, we'll check it later. Yeah, it hadn't closed. They're like, oh, we'll check it later. It hadn't closed. Now they're like, we'll see her again when she's free. So there have been people who had that it's closed up and it's if it's still there, we can
Ours did at 1.
You what?
Ours did at 12 months.
Yeah. Okay.
All right.
Can I ask one?
Oh, yes.
Hypotonia, is that sort of a direct, the constipation is sort of a direct result of hypotonia?
So yes, yes and no. So definitely hypotonic kids have constipation, right? You also have a large amount of nerves in your gut, just like you do in other parts of your body. And so it's also common that kids with brain diseases in general have constipation. So, you know, I think it is very, very common. It's something that we hear frequently. There are some disorders where we hear it more than others, even others with hypotonia and brain disease. So I think it remains to be seen, you know, where KAT6A falls on that spectrum. If there are really specific constipation GI problems that go above and beyond, you know, hypotonic kids with intellectual disability, or whether it just could be that. But the answer is yes, hypotonia and intellectual disability both have a correlation with constipation.
Is it possible that antibiotics can affect kids differently? The reason I asked for constipation, Sarah dealt with constipation for a long time, and then last year, about this time, she got an ear infection after her initial tubes fell out, which didn't clear. They gave her 3 rounds of antibiotics, increased their strength.
Yeah.
Through the end of April, and then the beginning of the SMA, her bowels went completely the opposite way. And starting in July, they had a sort of elimination diet. I mean, she was dairy-free, soy-free, everything free that you could think of. She was free of. And we're reintroducing things, and it seems like now she has an issue with eggs. Gluten seems fine. We haven't reintroduced dairy yet. Soy protein seems to be an issue, but not less of it. But these things weren't problems. I mean, she's 5.5. These things weren't issues at all until May. Is it possible that the runs of antibiotics could have
certainly we know that loss
permanently, or
certainly we know that loss of antibiotics can change your gut flora, which can then lead to lots of different GI problems. And how permanent that proves to be sort of depends.
Yeah, because we're trying to figure out if it's an allergy, if it's a true allergy, or if it's like
if it's something.
Absolutely.
Absolutely. Dr. Kelly, do you want to say something about constipation?
There is a specific So there is an intrinsic reason there are also
so I think we're gonna move on, because we'll be here and we'll be able to answer more questions, and we want to get through everything and make sure that you all get fed. So Dr. Kelly, do you want to go next? Whatever you prefer.